Spell my name again.
No.
Claire, it's Novo Nordisk. And he's also a doctor, but he's not sponsoring it. He just
Yeah, it's a different one, isn't it?
Yeah, all this
Tonight,
yes, Marlene, yes, of course.
That's what I've come to hear.
It's coming to here. Did you get the letter from last Friday?
Not yet.
Connie, very good. Glad you liked it.
And you saw another patient, Lillian Davis.
Yes, sisters, two sisters, yeah. My pleasure, my
I
pleasure.
moved up here last year. I did my master's in dietetics down there, so they employed me and I did my master's in nutrition. So that was yeah. We're really getting around already. I'm a little bit more planning. Both us are so interested in diabetes and the holistic package of it. So it's so fascinating as well because the kinds of different they want to do exactly. No, to tell you the honest truth, I met a guy who was doing my master's strategy project that had physiology of diabetes, and he was just, I'd worked with his mum actually, and he was just the most fascinating person because I'd known him for a year and I had no idea that he was so blind, no idea that he was like, he was paid his clothes and taught me a little bit more about it. It was so interesting how his life was pretty naive about it.
All right. Right.
And it's just so fascinating as well, and I really love the management's tricky. It's tricky to
Already have a seat here. Have a seat. Well, I'll be damned.
Yeah, that's good.
It's good, yeah. It's pretty.
What time are you planning on starting?
Once I talk about osteoporosis and I use the word steroids, more than many consultants. Even this school of consultants. In fact, I'm afraid you're here in the audience. You'll actually say something. That's what I said.
I don't think I could do that.
Okay, well,
I wouldn't be able to.
Be ready for the questions, the difficult questions.
Okay, so everybody, welcome to our first 2ML stroke matter session of the year. We have the monthly meetings on Wednesday afternoon, so evening. So thanks very much everybody for coming. My name is Dr. Paula Hegarty. I'm the GP coordinator and CPD advisor for the Transplant and Paramedic Local. I'm also the chair of the North Queensland subfaculty of the GP College, and I organise these meetings. So if you've got any complaints, suggestions, anything you want to suggest that we can develop, then I would be so delighted to hear from you. I would be excited. So tonight we're going to kick off with a talk about diabetes and hypothyroidism by Dr. Algenes. Dr. Algenes is a new endocrinologist in town. He's a diabetes and endocrine specialist. He's originally trained in Logan and Gold Coast and Huntsville, and he just loved Huntsville so much he decided to stay. So he's a new consultant, and he's also got an interest in general medicine and gestational diabetes. So before we welcome him to the platform, just the usual, the sign-in sheets are over there. I would love it if you would give me some feedback with the little feedback forms, and the bathrooms are at the back, as you will know. Okay, so welcome Dr. Algenes, thanks very much.
Thanks. So thank you everyone for attending in this rain. Thank you very much for Sarah and for Claire for helping sponsor this meeting. Thank you for all of you giving me a chance to talk today. We're going to talk about how to start insulin, what are the indications of starting insulin, how to start thyroxine, and what are the indications of starting thyroxine. Now before I even go into the very first slide, I would like to say that this talk has already been done by my illustrious predecessors over the last several years. Many of my consultants, my ex-consultants, my ex-supervisors who are now consultants this topic. And this is a great business case for you GPs to please possibly take back to your practice managers. Looking at these numbers, we presently have 3.61 million Australians with diabetes or pre-diabetes in a population of 23 million. So that's an average of 1 in 7 with diabetes. And this just came out in 2012 that a limb is lost in this country for every 3 hours due to diabetes. So now, if you add this and this together, one can just imagine how many patients you are going to get as GPs in your practice with diabetes. So here's the first take-home message already from the first slide. I wonder if you could kindly ask your practice managers perhaps to look into maybe advertising diabetes educators for every practice. So then you can get to see all these patients and your revenue goes up, your income for your practice will go up. So without much further ado, we will now move into the talk per se. So the short answer, how much insulin can you start for someone who needs to start? It's usually 8 to 10 units, that's a safe dose. What kind of insulin? When you first start insulin, it's usually a long-acting insulin. The usual insulin from different companies, from Sanofi Aventis, there's Lantus insulin, which is glargine, and from Novo Nordisk, there's Protophane insulin, there's Levomir insulin, and there's Novamix 30 insulin, which is the focus of today's talk. Now, you may ask me, why are you worried about bringing down HbA1c? What's the point in improving HbA1c? This study, the UK PDS, which was done in the last decade, showed that if you improve HbA1c even by 1%, you reduce the lower extremity amputation rate by 43%, you reduce the microvascular disease rate by 37%, you reduce myocardial infarction rates by 14%, and you reduce strokes by 12%. So that's the reason we always talk about dropping HbA1c in patients. Here's a little bit of a tidbit for you. The HbA1c units have changed. As of 2012 in this country, we are now allowed to use millimoles per moles instead of the old percentage figures. So from now on, if you see people using the term millimoles per moles, it was designed to make it easier for patients to understand their HbA1c as opposed to percentage figures. Now, type 2 diabetes happens to be a progressive disease, so it requires progressive treatment. What's the ballpark figure anyone in the audience would like to hazard a guess? From when someone is just diagnosed with type 2 diabetes until such time they usually need insulin. What's that ballpark figure, the number you can keep in your minds? How many years? Yeah, it's quite close. Usually, most patients, by the time they come to you and newly diagnosed with type 2 diabetes, they already have had the disease for a few years before they come to you. Remember, type 2 diabetes is two things. It's the obesity, which is insulin resistance, and it's a pancreas, which is not able to produce sufficient insulin. So islets, which are tiring and dying. Two things together will give you type 2 diabetes, and type 1 diabetes is autoimmune attack, so you get it from the very first day. So the correct answer is the ballpark figure number in your mind is 7 years. 7 years is, generally speaking, the time from when someone will be started on tablets for the first time with diabetes until such time they need to progress on to insulin. Now, the decision to initiate insulin depends on certain factors. For instance, supposing you have an 85-year-old lady in your practice who has had diabetes for the last 10 years. Do you want to prevent microvascular complications, macrovascular complications, etc., and be very strict with their blood glucose readings? No, you wouldn't, because the life expectancy is not expected to be beyond 90 or 100. So in such circumstances, it's okay to keep your blood sugars between 10 to 15, and you can even maintain such a patient on tablets, or even one small tiny dose of once a day insulin at night time, which lasts for 24 hours, like something like 8 to 10 units. That's perfectly fine. Very different to if you have a 60-year-old patient, an obese man who is a very busy businessman, who has had angina symptoms. Would you like to keep his blood sugars between 10 to 15 at all times? No. For such a person, you want to keep it to the targets, which is fasting blood sugars between 4.5 to 6 and postprandial 2-hour blood sugars less than 8 at all times. For such a person, you need to be strict. So the whole purpose of this slide is to say that tailor your insulin and starting insulin depending on what's the patient in front of you. I can also give you an example from the world of type 1 diabetes. Supposing you have a schizophrenic young man, say a 25-year-old schizophrenic patient who also has type 1 diabetes, and he forgets to take his insulin a lot. Do you really want to maintain his blood sugars between 5 to 10? Not necessarily, no. So for such a patient, it's okay to maintain the blood sugars between 10 to 15, but give them just enough insulin so that they don't go into DKA. That's the whole point of it. Now what really happens, the problem with diabetes, the whole problem with, but you can see the green line, the whole problem with diabetes is when you have normal, this is how for normal individuals with the 3 meals in a day, how the insulin gets secreted, but with diabetes you get less amount of insulin secreted with 3 meals of the day. So in the beginning, this is taken from the International Diabetes Federation's website, a flowchart as to what treatments you can give in the beginning, first, second, third step. In the beginning, you can try lifestyle measures for 3 months, which is exercise and diet. If that fails, then you can try metformin. Now, you may ask me, how do I treat these patients? I treat them according to what the PBS tells me to treat. In an ideal world, you can even start exenatide on day 1 for an obese type 1 diabetes patient. It's not wrong. But the PBS doesn't allow us to use exenatide. The PBS says start metformin first. Then the PBS says start glycoside second, or even start glycoside first and metformin second. The PBS says you cannot use ingredients like Januvia, like Tragenta. You cannot use those medications first up. You have to fail metformin or sulfonylurea in order to go on to ingredients. The PBS says you have to fail metformin and sulfonylurea. Only then can you actually get GLP and it looks like exenatide. The PBS also says you must fail tablets until you can go on to insulin. So the net effect is my treatment is now modified according to what the PBS tells me to do. So this is how we start treatment. We start with metformin and sulfonylurea, one or the other first. If the control is not okay with one or the other, join the two together. If the treatment is still not okay, you got incretins as the third line. And if the treatment is still not okay, you have insulin as the last line of treatment. Now, a little bit about exenatide. What is exenatide? Now, it was all found out when all of us eat food, we have something called incretins, which are secreted from our duodenum, which goes to our pancreas and tells our insulin, tells our islets to secrete insulin. These substances also go to your brain and cause satiety. So you feel as if you've eaten lots of food when you've only eaten a little bit. And these molecules also go to your stomach and tell you to work faster. So whatever food you eat, to work slower, so decrease gastric motility. So whatever you eat stays in the stomach longer. So the net effect is eating less. Then some very smart researchers thought, let's create the molecule ingredient itself in a lab and let's give it to the patients and see if it stimulates your own GLP-1 receptor and let's see if it does the job like your own ingredients. So they invented exenatide. They also invented liraglutide, which is Novo Nordisk's GLP-1 analog, trade name Victoza. And these molecules directly sit on your GLP-1 receptor. Remember, they're manufactured in the lab. They directly sit upon the GLP-1 receptor and tell your islets to secrete insulin, and the job is done, just like your own ingredients in your body. Then another set of smart researchers said, all your own native ingredients are usually broken down by this enzyme, dipeptidyl peptidase 4, short form DPP4. Let's invent something which inhibits the breakdown of your own dipeptidyl peptidase 4 so that your own ingredients stay longer and do the job longer. And that's where Tragenta comes in, that's where Januvia comes in. So they are just DPP4 enzyme inhibitors. They make your own native ingredients hang around longer. Thank you. So that's how these ingredients work. Now, why do I like ingredients so much? So, I've already had 3 patients already referred to me. One was a pilot, and one was a taxi driver, and one was a truck driver. All 3 obese males. All 3 need HbA1cs to be less than 9% in order to continue with their occupation. All 3 have HbA1cs between 10 to 11%. All 3 are desperate about losing their jobs. All 3 come to me at my clinics and say, we're about to lose our jobs, help us, our HbA1c is very high. So yes, of course, I send them to Vivian, the dietitian. Yes, of course, I send them to Elaine, the diabetes educator. But there's a shortcut. Many of them are completely non-compliant in medications or on just tablets. So what I do is for them, I start ingredients. Why do I start ingredients for them rather than insulin? Can anyone has that a guess? Why do I give exenatide and liraglutide for these obese patients? Weight loss, exactly correct. It causes profound weight loss. In fact, it's the only medication which causes weight loss in diabetes. are the GLP-1 analogs. Now, I don't like using GLP-1 analogs. Say, for example, if it's someone who's had diabetes for 20 years duration, say it's a 70-year-old lady who's already been on 3 tablets and her HbA1c deteriorating. I usually don't give GLP-1 analogs for such a person, even if she's obese. For such a person, she may or may not have mild CKD. I prefer to give incretins like sitagliptin, Januvia, or Trajenta, which is completely safe in CKD to use. Now, which insulins do we use when you first start someone on insulin? Assume your patient has been on tablets. Assume they have failed tablets, failed metformins, failed sulfonylureas, HbA1c is 8%, 9%, not improving. So the preferred insulin from the Sanofi-Aventis company is Glargine insulin, which is Lantus. From the Novo Nordisk company, there is Isofen insulin, their trade name is Protophane. From the Novo Nordisk company again, there is Novomix 30 insulin, which is the combination, 30% of it is a rapid acting insulin as part, and the remaining 70% is an intermediate acting insulin called Protophane. Which insulin do I prefer to use in type 2 diabetes? For me, after the patient has failed tablets, and if they are not considered for incretin therapy, I go straight for insulin. I prefer all of them, they're all the same. Please remember, you can also use Levemir insulin, but that's only for type 1 diabetes according to the PBS. For some reason, the PBS does not allow you to use Levemir for type 2. And it's an excellent insulin, a beautiful insulin for type 1 diabetes patients, which I happily use. But when it comes to type 2, I go straight away for Novomix 30 insulin. Or I can choose Lantus insulin, or I give Protophane insulin. Now you can see this triangle and this graph. This is from the NHMRC, which is the research regulatory body of this country. And its algorithm for what treatments to start, tablets first and insulin second, with ingredients in the middle, almost reflects the IDF, the International Diabetes Federation algorithm as well. In its purest form, you may ask me, how did you choose that number? 10 units of Lantus once a day, 10 units of Novomix 30 once a day, 10 units of Protophane once a day. How did you choose that number? In its purest form, the literature says it should be 0.2 units per kg body weight per day. That's the whole purpose of the slide taken from up to date. So 0.2 units per kg body weight per day will usually equate to about 8 to 10 units to start with. And that's how I got that number, 8 to 10 units. This slide is just to illustrate that if you have a younger patient, by that I mean age 40s, 50s, 60s, if you have a younger patient on maximal medication, for them, you would want to start insulin early, even if the HbA1c is slightly above 7%, because you want to prevent all those microvascular and macrovascular complications. Now here's a question for you. What are you going to do? Supposing it's a patient who's about 60 years old, who's on metformin and sulfonylurea, who's telling you they're losing a lot of weight, and HbA1c is worsening, 7% has gone up to 9%, and you call them after 3 months it's become 10%, and you're quite worried this patient may well need insulin soon, they're losing weight. How do you determine whether the patient is insulin deficient or not? Anybody want to say? So you can actually do the blood test and measure insulin and C-peptide itself if you really want to prove whether a patient is insulin deficient or not. You can simply do a blood test if they have failed the tablets, and if the insulin level is very low and C-peptide level is very low, you can say, yes, the patient is insulin deficient, so I can start insulin. I typically use this blood test for these pancreatitis patients. Some patients are alcoholics and they drink a lot and then they get pancreatitis. And because of that, even the endocrine function of pancreas is also destroyed, and therefore they don't have any insulin. So really to prove myself whether they have or have not any insulin, I usually do the C-peptide insulin levels of these patients. But you can even use them on non-alcoholic patients who don't have pancreatitis, just to confirm. And when it comes to geriatric age group, as I mentioned earlier, there really is no need to be very pedantic, no need to be very thorough. With blood sugars in single digits, you can happily keep them blood sugars between 10 to 15. Because for them, the priority is preventing hypoglycemias whilst not causing osmotic symptoms with high blood sugars. So the regimens most commonly started in clinics. Most of your patients are already on insulin, so already on tablets. By the time you get them sent to me, I will start them on insulin. And it's perfectly safe to start insulin on patients who already are on tablets because they're completely insulin deficient. But for practical purposes, as I said, you can start 8 to 10 units of this long-acting insulin once a day. Now for pregnant ladies, the safety data is mainly there for both the Protophane insulin, long term, and the safety data is also there for Lantus largely for 24 hours once a day to give to patients. That's why I prefer Protophane or Lantus for pregnant ladies. Now, how much insulin to start with? Most of the patients are going to be very reluctant when they first start insulin. They're going to be nervous. It's a big event in their life for them. So for them, it's nice to start with a small dose, and 8 units happily enough happens to be 0.0 units kg body weight per day, which is a small dose, so you can give 8 units first time for them. They may question you, am I going to get a hypo? You can tell them 8 units is so minuscule, it's very unlikely to cause a hypo in their scenario of diabetes. Now they might tell you, what time of the day do you want us to take the long-acting insulin when you first start insulin for them? The correct answer is usually you prefer to give it at bedtime, because even Lantus insulin has a small little hump, then it flattens out at a very low level, gets slowly released over 24 hours. So when that slight little peak occurs, it usually can coincide with whatever food they've eaten soon after dinner, which is why we give it at bedtime, so that they don't get hypos at 2 a.m. and 3 a.m. So it's very unlikely to cause a hypo, these long-acting insulins. So Novorapid is a very fast-acting insulin. It is released abruptly and quickly drops the blood sugars down. Whereas Lantus, Protophane, and Novamix 30, they're very slow acting like this. And I'll show you the profiles of Novamix 30 very soon on the slides. Now, hypoglycemia is a tricky area. Some of your patients may be on glycoside and you're starting them on insulin. So yes, there is a risk of them getting hypos. So you must not be scaring your patients and say that you're going to get hypos, which must be done very tactfully, which I'm sure if you do extremely well. And it's also to reassure your patients with type 2 diabetes that if I give you insulin, the hypoglycemia is not going to be very severe as opposed to a type 1 diabetes insulin, because you have counter-regulatory hormones like glucagon, etc., still functioning in type 2 diabetes. Now, how do you titrate your dose of insulin? The best thing is to ask the patient to do the first blood sugar reading in the morning, the fasting blood sugar, and then ask them to come to you every 3 days if you can see them every 3 days. Most of you are quite busy, you may not be able to do so, but in the purest form, try to see them every 3 days. And if the capillary sugar exceeds 8 millimoles per liter on 3 consecutive days, then you can increase it by 2 units by 2 units per day. And that's how you can slowly increase the Lantus dose from 10 units starting dose up to 12. You'll see them after another 3 more days. The capillary sugar is still greater than 8 for 3 consecutive days, and you can push the dose up from 12 to 14. That's how you can give them a good base of control. Remember, these patients are also still on the tablets. Now, sadly, insulin is an anabolic hormone, so it will make you put on weight. So that's where the vicious cycle concept comes in. They put on weight, they become more insulin resistant, and then you need to give more insulin to fight it. But really, what are we treating here? We are treating the prevention of microvascular and microvascular complications. So putting on weight is just a small trade-off. It's easy for me to say that, but many of your patients may not agree with it. But that's the best treatment we have. How much of HbA1c benefit can you get when you start insulin? You could reduce your HbA1c even by 2%. So then patients come to our clinics, and in our experience, after 6 to 12 months, a further dose of insulin dosage is required because the diabetes progresses with time. But some of your patients may be so switched on, they will exercise so well, they will eat such a good diet, they may actually not need any further increase in dose of insulin. But in time, all patients generally need their insulin dosage to go up. So now you have started your patient on once a day insulin at night time. You are checking their blood sugars every 3 days. You have made sure the blood sugars are in single digits according to the targets, 4.5 to 6 before meals and less than 8 after meals. The patient done very well, and now they're needed about maybe, for example, 50 units 6 months down the track, once a day of either Lantus insulin at night or Protophane insulin at night, or Levomir insulin at night. That's fine. You're doing very well. But also to remember that if your patient has deranged LFTs, you may need more insulin because that's a sign of insulin resistance. Now the whole purpose of this slide is what to do with tablets. You may choose to discontinue the tablets once you have started the patient on insulin. That's absolutely fine. If there is one tablet you want to be continued, say the patient is on linagliptin, metformin, and glycoside, you are allowed to stop. You want to stop 2 of these tablets and start the patient on insulin. The patient is on 20 units of Novamix 30 once a day, doing extremely well. Now you want to stop some of the tablets. Which one would you like to stop among these three? Is your first choice? Absolutely correct, yes, because that's the one which causes hypos. Sulfonylureas is one you want to stop first. Then you want to stop something like the incretin tablets second. Because incretins have a very small impact, just 0.5% reduction in HbA1c, not great. It really is just a bit of a halfway house, like buying time, like stalling time before you give someone an insulin. It's really not going to drop HbA1c by much, so I usually don't bother much, and I have very low threshold of stopping all these incretin tablets. So the best tablet to continue is metformin. Why is it so good to continue metformin? Even when the patient has absolutely no islet cells left behind. Because metformin works that way. It reduces your insulin resistance by unknown mechanisms. It reduces insulin resistance, and you also give the patient insulin as well. So 1 plus 2 will add up. It will be synergistic, and the patient will have extremely good blood sugars and extremely good HbA1cs with time. Now you may ask me, if you stop a tablet, do you need to increase the dose of insulin to compensate? And the answer to that is yes. You may feel that if you stop glycoside, the patient may come with slightly higher blood sugars 1 or 2 weeks down the line, and you may need to slightly increase the dose of insulin by perhaps 10 or 20 units, maximum not more than 30 units, to compensate for each tablet which you have stopped. And the whole focus of this talk today is going to be Novamix 30 insulin. So this insulin is, it lasts for 24 hours, and I've got graphs very soon. So this insulin should not be given at bedtime. You can give Landis insulin at bedtime because that has a very flat profile. That's entirely made up of long-acting insulin. But Novamix 30, remember that 30% of it is rapid-acting insulin. So if you give it at bedtime, the patient will get hypo. So the time to give it is soon after meals. Soon after or just before the start of dinner. That's the time to give it, so that 30% of it acts over the dinner, and the remaining 70% lasts for the next 24 hours. Now you can adjust the dose of Novamix 30 once or twice a week based upon, again, the lowest of 3 blood sugars of pre-breakfast blood sugars that the patient right in the book can show to you. Or you can even take the average of 3 blood sugars, and if it is above 4.5 to 6, then you can gradually push the dose of Novamix 30 up. You may ask me, how much is the minimal increment of insulin dose you're allowed to do for any insulin? The ballpark figure is 20%. The minimal dose, which in order to give any meaningful benefit to the patient, both upwards and downwards, is 20% of insulin. Whatever the dose is, 20% of it, if you increase it, decrease it, that's going to have a positive negative impact. So if you want to stop someone, if you want to reduce someone's insulin, you reduce it by 20% at the bare minimum to have a meaningful effect. Or if you want to push up someone's insulin, you need to increase it by 20% to have a meaningful effect. So now your patient comes to you and they have all these blood sugar readings written in their book. Supposing they have patient who started on 8 units starting dose, Novamix 30 today, and they come back to you in a fortnight, and the blood sugars are greater than 10, all the values are still greater than 10. So you can quickly go up from 10 units to 16 units of Novamix 30 with dinner. Or supposing your patient, you've started on 8 units of Novamix 30 tonight, and they come back to you next week with hypos. Blood sugar is less than 4.5, then you can reduce the dose of Novamix 30 easily. So all this is given in the product literature as well. Now, reassess the need for oral hypoglycemic agents once you have started the patient on insulin, as I mentioned earlier, and you can stop tablets as you increase the dose of insulin further. Now here's a slide about Novamix 30 insulin. So in the beginning you can start it at dinner time, and the 30% of it quickly peaks up like this and drops down the blood sugars, and the remaining 70%, the longer acting, it's intermediate acting form, lasts for about 24 hours. So you can start it at dinner for your patients, 8 to 10 units, and just as in the previous slide, look at how the blood sugars are over the preceding 1 or 2 weeks, and if it is very high, you can push the doses up. If you don't want to go by 6 units too abruptly first up, you can definitely go by 20% increase, say by 2 units each time or by 4 units each time they see you. Now assume you have reached up to 50 units of, say 5 months have passed, you've reached up to 50 units of Novamix 30 at dinner time for this patient. And the HbA1c has actually worsened from 8% to 8.5%. Now the good thing about this insulin is you can use it twice a day. So then you give it twice a day like this. You can give it once at dinner, and you can also give it once at breakfast. And again, you can start the breakfast dose at a small dose like 8 units, keep the dinner dose at 50 units, stack those. And again, work on the breakfast dose and make sure that the pre-meal blood sugars before breakfast and before lunch and before dinner are within the range of 4.5 to 6. Now, most patients will do well with this, but assume we have treatment failure. Assume despite your best efforts, we have progressively increased the morning dose as well. And now we have reached 50 units in the morning, 50 units at night, and the patient still has highish blood sugars in the afternoons, before and after lunch. So another good thing about insulin is you can even use it 3 times a day. So you use it 50 units in the morning, you now got 50 units at night, you can also start 8 units in the afternoon and slowly build up the afternoon dose up as well. And even studies, this has now been proven, this regime, to be as good as the basal bolus regimen of large yield insulin and Novorapid 3 times a day. So this Novamix 30 is just as good as the basal bolus regimen, which means basal bolus means 3 rapid acting insulins before each of the 3 meals and 1 long acting insulin like base at bedtime to cover for 24 hours. Now this is a new slide. It's generated a bit of controversy, but let me get it through. This is for gestational diabetes. There was a study in the last decade called HAPO, H-A-P-O, which stands for hyperglycemia and adverse pregnancy outcomes. So this study found out that all these gestational diabetes patients, if you use the traditional fasting blood glucose cutoff for the 75 gram oral glucose tolerance test, which is 5.5 or greater, there are risks for developing bad fetal effects such as big babies and high insulin in the baby, even with blood sugars between 5.1 and 5, or even lesser than that, rather than just using the cutoff of more than 5.5. So what I'm trying to say is that these were the old cutoffs of 75 gram oral glucose tolerance test, fasting more than 5.5, 2 or more than 8. But they found out even these cutoffs may not be good enough to prevent the risk of the baby becoming big in gestational diabetes patients. So then this study resulted in a big international body called IADPSG being formed. And this body stands for International Association of Diabetes and Pregnancy Study Group, met in 2010 somewhere in California. And then they came out with the new guidelines for 75 gram oral glucose tolerance test. So as you can see, they have lowered the fasting blood glucose threshold from 5.5 to 5.1. So in this country, you have 9% of all pregnant ladies are the ballpark figure using the old guidelines of 75 gram OGTT are going to be diagnosed with gestational diabetes at any time. Now using these new lowered guidelines for fasting blood glucose, the number of gestational diabetes patients are going to be increased from 9% to 14%. And that's what's the controversy. Can the public health system cope? So I know Sullivan and Nicolaides. If anyone's here from Sullivan and Nicolaides, they're already using these new lower guidelines, and it's offset from the HAPO study, and it's known as the IADPSG guidelines. And I personally use these new guidelines because from evidence I know if I ignore these guidelines, I'm exposing at least 5% of pregnant women to more risks of their babies being born big. So it's better I treat all of them, so I'm happy to see more patients. So the conclusion is, the inevitable need for insulin therapy in most patients should be discussed quite early in their treatment. That ballpark figure of 7 years from the time you first see them and put them on tablets to the time they need insulin. I have seen exceptions. Some patients are managing quite well with tablets for 30 years. Some patients fail within 2 or 3 years and they need insulin. There are exceptions. But general ballpark figure to keep in the mind is usually 7 years. So continuously when you see them in clinic, the topic should be breached and eventually one day you may need insulin. So at least psychologically they get a picture in their mind. So when the day comes, it doesn't become a shock when you have to tell them that they need to start insulin. And diabetes educators are very, very useful in this scenario. Diabetes educators can be an additional ongoing source of support and information for your patient at the time of changeover from tablets to insulin. So, given the huge number of diabetes patients in this country and given the fact that one limb is lost every 3 hours in this country, it makes sense for all GP practice managers to possibly employ diabetes educators in every practice and possibly even employ podiatrists in every practice because you have the figures in front of you and that is only going to increase your income in the practice. So it's something, a very important take-home message which I wish to convey today. Now I move on to the second section of my talk, which is hypothyroidism. Now, we have this fantastic system, just to recount. We have TRH, thyroid releasing hormone from all of our hypothalamuses. That's neural tissue in the brain, and that secretes the hormone, which then goes to your pituitary and touches your thyroid lobes and tells you to secrete TSH, thyroid stimulating hormone. And TSH then comes and touches your thyroid and tells you to secrete T3 and T4, which then goes back to your pituitary as a negative feedback loop. That's normal physiology. So what would happen in hypothyroidism? You would expect the TSH to go very high and the free T4 and free T3 to go very low. Finding a high concentration of thyroid stimulating hormone in a symptomatic patient almost virtually confirms the diagnosis that the patient has hypothyroidism. And such patients usually need lifelong thyroxine tablets. Now, commencing thyroxine can aggravate cardiac disease, so I'll tell you how to start thyroxine in patients with cardiac disease very soon. And the concentration of thyroid stimulating hormone is used to monitor the therapy of the patient in coming months. I'll also tell you why thyroid stimulating hormone is better than free T4. So how to dose thyroxine? So usually primary hypothyroidism is treated by giving the patient replacement thyroxine, usually for life. The thyroxine half-life is about 7 to 10 days, and once daily dosing is more than appropriate. So adults who need, adults usually the ballpark figure is 1.6 to 2 micrograms per kg body weight per day. So as most areas of medicine, all medicines always dosed on body weight. And even you saw insulin, 0.2 units per kg body weight per day, the starting dose of once a day insulin. Same thing here, 1.6 to 2 micrograms per kg body weight per day is the thyroxine starting dose for someone who has hypothyroidism. But one must not start, if the patient needs 150 micrograms per day, one must not start 150 micrograms on the very first day because that will precipitate heart failure. So I will come to how to deal with these patients. So suppose it's an elderly patient who has heart disease, known case ischemic heart disease, now known case of hypothyroidism, and you start the patient 25 micrograms. That's the best way to start it. Start with a small dose at 25 micrograms per day, and every 3 to 4 weeks you can gradually increase it by 25 micrograms until you reach the target dose. Supposing according to body weight it's 125 micrograms the need for the patient, it's at 25 micrograms per day on first day. Every 3 to 4 weeks gradually build it up until you reach 125 micrograms per day. On the contrary, supposing you have a patient who has Graves' disease and the free T4 is 100 and the TSH is suppressed, and assume you have sent this patient to one of the thyroid surgeons and assume the thyroid has been surgically removed. Now, do you want to start on 25 micrograms once a day for this patient? First day post-operatively? No, because the body is already used to 100 micrograms, or body is already used to that 100 micrograms per day of thyroxine because of overacting thyroid. For such a patient, you can straight away start on 100 micrograms per day. But usually such patients are inpatients in hospitals, so I usually deal with them. So you won't be seeing them first up. But you'll be seeing them when they get discharged. I'll send you nice discharge letters. Now, how long does it take for the TSH to normalize? So it may take about 3 to 4 months until the full effect of the drug is felt by the patient. Because TSHs, remember, is coming from the pituitary and these cells are rather slow in the pituitary. So it takes about 6 weeks for any change in the TSH to be meaningfully recorded in the blood. That's why it's no point doing TSHs every week. Actually, it's more better to do it every 6 weeks. That way you get, or even every 4 weeks, every 4 to 6 weeks we say, to look at any meaningful change in TSH. Now this is a bit too much, about 6 half-lives of thyroxine. We'll probably skip this slide. But what we can say is, as long as you do your TFTs every 4 to 6 weeks, you're all right. And gradually when you give the patient thyroxine and slowly build the dose up, you notice the free T4 going up and the TSH falling down back to normal. Once all the numbers reach normal, that means the patient is fine. What if you have started thyroxine for the patient, you have gradually increased the dose back to the target range according to body weight for the patient, and the patient still has a very high TSH? The common cause is usually non-compliance, quite common. Some people are working, they can't have the time in the morning to sit down and take the tablet and wait for half an hour and then consume breakfast, so they just choose to skip it. So in that case, we have ways of dealing with that. We sometimes ask them to take the tablets at night. Another thing we do, especially for the pregnant ladies, many of them are on oral iron supplements, and these oral iron supplements impair your absorption of thyroxine. So for them, we tell them take your thyroid tablet at night and take your iron tablets in the morning. Very simple solution for pregnant patients. Now, thyroxine in pregnancy. What if you have a hypothyroidism patient, bond or autoimmune hypothyroidism, Hashimoto's disease, a 25-year-old girl, you started on the right dose, you managed to get TSH back to normal. She's now on 150 micrograms per day. And she rocks up to your clinic, and now she's 27 years old, 2 years on track, she's pregnant, 2 weeks pregnant. What do you have to do with the thyroxine dose? The big fear is that the thyroxine is not appropriately given to pregnant women. Pregnant women need more thyroxine. The baby will be born with severe low IQ. It's known as cretinism. So straight away, if someone is already on thyroxine in the past and they walk into your clinic saying we are pregnant, you can happily increase the dose straight away by 30% in the first instance. Thyroxine in pregnancy, this is a whole area altogether, and a brilliant